Hi friends, today we're going to talk about hierarchical condition categories and how they're essential to value-based care. Our objectives here are to understand the background and the meaning of HCCs, understand the HCCs with a case, what is the financial impact of HCCs, and what is the relationship of HCCs with population health management and value-based purchasing. First question is, what are hierarchical condition categories? Now, these are risk adjustment and coding models that are mandated by CMS. They were initially started in 1997. And the basics are, these are a system of medical coding used by insurance companies to determine patients' future medical needs for the next year. Now, only life-altering medical conditions are recorded in the medical coding, such as diabetes, end-stage renal disease, CHF, and etc. And we'll talk about these in the future slides. So as we mentioned, basis of reimbursement for Medicare Advantage plans since 2004. What they help in is prediction of costs. So with accountable care organizations and the hospital value-based purchasing program, these have gained a lot more importance for cost predictions and accountability because providers are assuming more accountability and subsequent risk. So a little bit about the basics. There are two types of HCCs, one developed by the CMS and the other developed by HHS, or the Department of Health and Human Services. The ones from CMS predict spending for Part C, or Medicare Advantage plan members. They predict non-drug medical spending and are applied for patients whose age is greater than 65 years. On the other hand, the HCCs developed by HHS are for commercial payer populations. They predict both medical and drug spending and are applicable for all ages. So in case of CMS HCCs, these are prospective, which means the current year data determines the future year risk. Now, these are based on data from various sources, whether hospital principal and secondary diagnosis, hospital outpatient diagnosis, now specialist and primary care physicians' office diagnosis, that includes physician assistants and nurse practitioners, as well as clinically trained non-physicians, which are psychologist and podiatry office visits. Now, Medicare assumes a risk score of 1 for the average beneficiary. Now, risk adjustment is based on age, sex, Medicaid status, disability status, and if patient is living in an institution. Currently, there are 79 categories of HCCs from 25 disease categories, and within each category, there are hierarchies that represent more advanced and costly conditions with a higher coefficient. So a simple slide here saying when ICD-9 was used, there were 14,000 ICD-9 CM codes, and currently there are greater than 70,000 ICD-10 CM codes. Now these form 805 diagnostic groups, 189 hierarchical condition categories, of which 79 CMS HCC categories are used in the payment model. Now, CMS has requirements for the use of HCCs. So, one, the presence of the condition should be noted every calendar year. The provider's assessment and plan for management of the condition should be noted, and these conditions must occur at least once in each calendar year. Looking at the breakdown of HCCs, one, the documentation of the condition needs to happen. This is a yearly documentation of both acute and chronic conditions. The provider needs to write what is being monitored, what is being evaluated, assessed, and treated. And the source of this data should be from office visits, ER visits, hospital inpatient, and outpatients. Let's look at some current metrics. HCCs can affect about 2 to 5 times of base payment. Now, Medicare Advantage plans cover about 13 million lives, and 27% of people in the healthcare program are the elderly, where HCCs can be applied. Looking at this map from CMS, this is the share of Medicare beneficiaries enrolled in the MA plans by state in 2012. And as you can see, some of the states on both the east and west coast have more than a third of beneficiaries enrolled in these plans. Now, this is the table of HCCs that is included in the CMS HCC risk adjustment model, as well as the brief description of the disease. What is the value of an HCC? Now, as we've put in, this could be a very high dollar amount per member per month. Now, greater than 3,000 diagnostic codes that map to HCCs, and they have compounded payment value, which means that if you have 1 or 2 or 3 or more chronic conditions, there is a disease interaction coefficient that adds to the value of the HCC. Big question for the providers here is, why do HCCs matter? Well, one, they're tied to revenue. Because they predict future financial utilization and risk, it's important to know and document your case mix index that's affected by what you write in the chart. This is what forms the basis of the risk adjustment factor, or the RAF score, that reflects complexity. And we'll talk about how the RAF score is calculated. Now, what is important is it helps with optimizing inpatient clinical management, because you need to document to capture the full complexity of the patient. Let's look at a slide about risk scores. Now, this is, as we've mentioned, the HCC algorithm is used by CMS to predict risk of future medical payments. This is based on a risk adjustment factor, and that's a numerical measure of quantity of at-risk status of the patient. It's comprised of two cofactors, such as the demographic risk adjustment factor and the disease risk adjustment factor. Now, demographic RAFs, these are determined by age and gender. However, disease RAFs are equivalent to group RAFs and interaction RAFs. Now, each HCC disease group represents a disease or a family of diseases. So the group risk adjustment factor is the sum of all disease groups to which the patient belongs. However, there is an interaction RAFs, and this is basically a bonus factor applied if patient has 2 or more conditions that negatively impact each other. Now, we're going to talk about this looking at an example. So let's assume there is a 76-year-old female with diabetes, peripheral vascular disease, congestive heart failure, who presents to the clinic for a medication refill on January 5th, so beginning of the calendar year. She's seen by the nurse practitioner and medications are refilled, recommended follow-up in 3 months. Unfortunately, there is a no-show in March, and in July, there is an ER visit for sore throat and prescribed antibiotics with follow-up with PCP. Just looking at the red box and not reading what's lower, I'm going to move on to the next slide. Now, just based on documentation, the financial analysis of use of this HCC is in the yellow box here. So 76-year-old female, that gives an RAF of 0.468. She's Medicaid eligible, that gives her a 0.177. However, in this case, diabetes hasn't been coded, vascular disease, CHF has not been coded, and so there is no disease interaction. Her total risk adjustment factor is 0.645, equivalent to $484 of payment per month, and that gives the clinic or a payment of roughly $5,800 per year. So let's look at this patient where we have more documentation. Now, the initial scenario remains the same. The lady had presented to us in January for a medication refill, a no-show in March. In July, there's a ER visit for sore throat. And she shows up to the clinic in September. She's seen by her primary care physician. Diabetes is addressed. Medication changes are done. Labs are ordered. Counseling has been done. The primary care physician addresses the peripheral vascular disease, orders an ABI, medication changes, and then notes all other normal with no changes. Now, just based on the information here, our HCC model moves into the green condition here. So these are some of the conditions that are coded. Now, we do get points of the RAF for the age, the Medicaid eligibility. However, we can add the 0.181 for diabetes, and that puts her in the HCC 19. Now, there is vascular disease, the HCC 105, so she gets 0.324 points on the RAF there, and the total RAF turns out to be 1.150, equivalent to a per member payment of 863 and an annual payment of little more than $10,000. Now, had we coded all the conditions appropriately, and so that comes to the slide where we had talked, if the physician had documented the diabetes, the vascular disease, the CHF, that would have given an RAF of 0.395 for the CHF. There would be a disease interaction RAF bonus point, and the total RAF would be 2.497, monthly payments of 1873 and annual payments of more than 22,000. Now, this is the same patient. It's just that the conditions needed to be captured in that calendar year, and the acronym of MEET, which was monitored, evaluated, assessed, and treated. So every condition that's noted, there has to be documentation that it was actually being looked at. Now, CMS released a final report of the risk adjustment model, a 127-page report where it talks about the basics of risk adjustment, the basics of HCCs. Now, there's some more profiling beneficiary groups defined by functional impairments. There's a chronic condition special needs plan. And again, this document is available for review with the link. So to recap, a risk adjustment factor is the total score of all relative factors related to one patient for a total year. And so you have points for age and sex, community-based or institution-based, Medicaid disability and interaction with age and sex, the HCC category based on diagnosis reported, interaction between certain disease categories, interaction between certain disease categories, and disability status. So the raw risk score, or the patient demographic score, in addition to the health status or the accurate documentation of patient's health status by billing the proper ICD-10 codes, gives us this raw risk score, which significantly affects total payments. So each HCC is assigned a coefficient score, and as we discussed in that example, when coefficients are added together, they produce a coefficient aggregate. Now, when the coefficient aggregate is multiplied by the multiple other factors, they produce this risk adjustment factor, which is used to determine the additional payments. The CMS model also includes a set of disabled status interactions. So female who has cystic fibrosis and is disabled, she receives an incremental payment to account for her higher expected costs. There are certain principles for risk adjustment model, and I'd encourage you to pause here to read this. However, the boxes in red are the major principles. So principle one is disease categories or diagnostic categories should be clinically meaningful. They should predict medical expenditures. Now, diagnostic categories that will affect payment should have adequate sample sizes to permit accurate and stable estimates of expenditures. Principle 4 is, in creating an individual's clinical profile, hierarchies should be used to characterize the person's illness level within each disease process, while the effects of unrelated disease processes could accumulate. Principle 5 is the diagnostic classification should encourage specific coding. It should not reward coding proliferation. Providers should not be penalized for recording additional diagnosis. The classification system should be internally consistent, should assign all ICD-9 CM codes, and this is based on the document released prior to ICD-10. Now, anything after October 1st, 2015 has to be done under ICD-10. And discretionary diagnostic codes should be excluded from payment models. And this is part of the document that CMS had released, and I'd encourage you to go through that document to get a better understanding of all these principles. An example from the CMS document, and again, this pertains to ICD-9. However, this has been updated with newer documents pertaining to ICD-10. The example given by CMS is a 76-year-old female with acute MI, angina pectoris, emphysema, chronic bronchitis, chronic renal failure, chest pain, and sprains. It's noted that this patient lives in the community. with several chronic conditions. And so in this case, 8 ICD-9 CM codes from the hospitals and the provider visits was accumulated, as well as from the hospital. And this was categorized into 7 diagnostic groups, 6 condition categories, and 3 payment hierarchical categories. And what they have determined is what can be used for HCCs and what cannot be used. Now, looking at this slide, you see the top 2 of acute MI and unspecified angina codes to an HCC of acute myocardial infarction, or HCC 81. The chronic bronchitis and the interstitial emphysema codes to 108 COPD. Chronic kidney disease and renal failure codes to renal failure of 131. What cannot be used is unspecified chest pain and ankle sprain, because these have been determined to be either linked to an HCC or non-significant in terms of the chronicity. So in this patient's case, she gets a risk factor of 0.457 for female and age group. HCC of 81 gives her 0.359. COPD HCC 108 gives her 0.399, and renal failure 0.368, giving her a total of 1.583 and payments or a prediction of $11,000 per cost per year. So the predicted expenditures and the risk score. Now, predicted dollar values are from this version 12 age-disabled CMS model. Now, there are various models that CMS releases, and this calculation was based on version 12. As of the time of this review in April 2017, the version 22 is being used. So along with the demographic factors of age and patient being a female, 3 payment HCCs were identified: the acute MI, the COPD, renal failure. Her total predicted expenditures are the sum of these individual increments of roughly more than 11,800, and the total risk score of the individual factors was 1.583. Now, there are 3 different circumstances where HCC scores are used for payment consideration. One is with Medicare Advantage plans, where the gross payment to the HMO is increased as a result of these scores, and this payment is made to the HMO. In terms of accountable care organizations, where cost savings are calculated with the HCC predicted expenditure used to determine the savings, and this payment is made to the HCO. Now, in the medical home model, where per member per month payment for patient-centric care is calculated on the aggregate HCC score and the level of the medical home accreditation. So, for example, if HCC aggregate scores is 2 or above, the patient-centered medical home is a tier 3, and the highest payment model or the payment would be received by the practice. Another case is a 79-year-old male with diabetes without complications, epilepsy, hypertension, and chronic kidney disease stage 4 with schizophrenia. Now, the risk adjustment factor score is 1.558. However, if there is a causal relationship, so if the provider documents the relationship of diabetes with chronic kidney disease as a cause of nephropathy, then it changes to HCC 18, which is valued at 0.368 rather than HCC 19. And that 0.25 point increase can bump up the total risk adjustment factor score. So providers need to not necessarily just document each diagnosis, but if there is a cause relationship, they need to document that. So diabetes, insulin dependent with nephropathy as a cause of chronic kidney disease. Indeed, if that is the case, that needs to be, again, documented in every calendar year. Now, expansion of HCC use. This is being used, and as we said, across hospitals, primary care clinics, ACOs. So the diagnosis must be based on a clinical medical record documentation from a face-to-face encounter. They are coded according to the ICD-10 guidelines for coding, assigned based on dates of service within that data collection period, and that has to be each calendar period, and submitted from an appropriate risk adjustment provider type as well as an appropriate risk adjustment physician data source. So CMS auditors will assume that they have audited an appropriate sample of codes and correct the entire payment amount by sample error rate. So extraordinary exposures, so a 5% error rate in the sample will result in a 5% reduction in premium. That could be huge. Now, organizations need to have robust ICD-10 code list to be accessible by providers. And how do we get providers to use HCCs or at least understand their meaning? One is educational webinars like this one, but again, they need to be provided the tools. So one is having them look at ICD-10s. There needs to be an optimized means of identifying HCCs and treatment HCCs. Internal audits of the validity of ICD-10 codes that are being used to a particular patient, and then document and evaluate each use of the HCC. Now, why we're doing this presentation is to help providers understand that they need to protect revenue with accurate and complete HCC coding. So a dynamic provider-controlled process through the selection of valid ICD-10 codes. Number two is we want them to be compliant, supporting documentation in the medical record and document all the disease processes. Three is clinical document improvement activities to promote specificity in the notes. And number point four is an internal audit of the provider documentation and then give them the post-audit feedback. How do we improve care in this new world of ICC use? One is we need to assess the beneficiary's morbidity scores based on the claims. So let's measure what the beneficiary has. Two is capture. So we need providers to capture the clinical information in EHRs to support the diagnosis. And three is to analyze. So the risk score analysis to evaluate for the impact on revenue. What we use at Aerolib is a HCC risk calculator and ICD-10 mapping. And so what we are currently using is CMS version 22 for the ICD-10 code set for all cases after October 1st, 2015. We have a code set for ICD-9. We add our ICD-9 codes, the input, the gender, age, the eligibility, the Medicaid status, institutional status, and then we calculate the various HCCs that pertain to this patient. I bring you back to this slide that we talked about. There's a financial analysis for HCC, both in the blue, green, and yellow boxes, based on a same patient, but the lack of documentation. And from a institution or a clinic standpoint, that could mean the difference of more than 4 times of payment that is being received, even though the care provided has not altered. So this was the basics of HCC, and what we'd want you to do is go back through this presentation, read the articles from the CMS to get a better understanding. If there are certain cases that you'd like to run by us, we'd be more than happy. You can reach us at cmo@aerolib.com or visit aerolib.com and click on the contact button. Thank you so much.